Good morning, good evening, good afternoon, everyone. Thank you so much for joining us today. And as I see more people coming in, I think we will go ahead and start. So welcome to our webinar titled Saving Lives and Livelihoods, focusing on the role of water, hygiene and sanitation, and equity in AMR response. My name is Dr. Masika. I'm the Global Health Policy Manager at the World Federation for Animals, where I lead the work on AMR, Pandemic Prevention, Preparedness and Response, and the liaison to the United Nations Environmental Programme on the nexus between health and the triple planetary crisis. I'm also a veterinarian and a One Health expert, and today's conversation is very close to my heart. Now, I will start by giving a bit of a background on why we have this webinar today. So it's been almost a year now since the Global Strategy Lab brought together experts from different regions and different health expertise to try and come up with a unifying goal on AMR. And the goal 1-10-100 proposes to unite the world using a One Health approach to safeguard human health, animal welfare, agri-food systems, and the environment to ensure that it's protected against emergence of drug resistance infection and microbes. Now, specifically, this goal proposes to save over 10 million lives by 2040 in a concerted effort to prevent infections. And if infections occur, they're treated appropriately so that the vitality and effectiveness of antimicrobials are sustained. Secondly, the goal commits to ensuring that antimicrobials are first available to all, but also affordable and used prudently to ensure that they're secured for the future. And with this backdrop is why we are having this webinar today. Now, I have an interesting panelist today, and I want to start by introducing the women or the ladies. I will start with Angela Nkuru, who is a founder and lead of White Ribbon Alliance Kenya, and she co-chairs the global movement. She's very passionate about reproductive, maternal, and newborn health, and she led a campaign on what women want, championing ask, listen, and then act approach in health programs to ensure that women, girls, newborns, and midwives in under-resourced regions are prioritized. Thank you for joining us, Angela. Then we have Dr. Fiona, who is a research fellow at the Global Strategy Lab, where she champions global strategy on AMR, and she's a veterinarian, a practicing veterinarian with a lot of experience in infectious diseases surveillance and has worked a lot in the policy-making space within the One Health realm. She has previously also held positions with the Veterinarians Without Borders, World Fish, and livestock and research and virology research in Australia. Thank you for joining us today. And finally, we have Dr. who is a hygiene lead at the WaterAid UK. He is a behavior change scientist, public health and WASH expert for over 20 years. At WaterAid, he leads the global hygiene behavior change portfolio across Africa and Asia. He also has a PhD from the London School of Hygiene and Tropical Medicine and has 2 master's degrees, both in public health and social sciences. Now, today's webinar will follow a short format. We'll have a quick presentation from Dr. Fiona, who will talk about gender analysis or incorporating gender analysis in AMR research. This will be followed by a moderated Q&A session, which I'll moderate, and the panelists will answer some of the questions, especially from the audience, which we encourage you to put your questions in the Q&A box at the bottom, and we will try as much as possible to answer them. Now, as we are waiting for Fiona to come in with the presentation, please just take a few minutes to introduce yourself in the chat. Tell us where you're joining us from in terms of your region, what you do, and your organization. Welcome, Dr. Fiona.
Thanks so much, Masika, and thanks again for having me and moderating this session. So, as you said, this is also something that's very near and dear to my heart as well. So, this will be a really brief presentation, just discussing one of the projects that we've recently completed at the Global Strategy Lab. And this project was completed in collaboration with the International Livestock Research Institute in Nairobi. So for this project, as Masika mentioned, it was focused on developing a framework for helping researchers incorporate gender into their projects that were looking at AMR, specifically in livestock systems. So as I mentioned, this project was completed in collaboration with ILRI. So I just wanted to highlight all the work that they also put into this project. So a big thank you to Alessandra, Arshni, and then Susan, who also contributed to this project. So as a quick kind of introduction and background, we undertook this project because we realized there was a big lack of gender consideration in AMR research. So it's not something that's often considered. And it's important because if we do ignore gender considerations, it can definitely lead to unsustainable interventions and equity gaps. So it's really crucial that we do consider it in order to develop sustainable research programs and policies going forward as well, too. So as I mentioned, we wanted to develop a framework and a list of research questions that researchers could use to apply to the projects that they were undertaking, focused on AMR and in livestock systems. And this would hopefully be a way for them to help improve their gender considerations in livestock systems. So what we did for this particular project is, firstly, we kind of conducted a narrative review just to identify what the key entry points for gender were for how it kind of impacts AMR, specifically in the agricultural or livestock system space. Once we had that information, we then applied a health system gender framework to the research that we had consolidated. So specifically, we used Morgan Ayal's gender health system framework for that. And then that information we combined together, and we used that to develop a list of research questions that researchers could apply going forward. So what we found, first, as I mentioned, we did that narrative review and we applied a gender framework that was already in existence to it. So this was a conceptual framework we developed from that. So we identified a few different entry points for gender in AMR. So specifically, we found that gender could impact AMR exposure. It could impact antimicrobial use, which I think is a little bit more clear. And then it could also impact the outcomes of resistant infections as well. So we combined this together with Morgan Ayal's framework, as I mentioned, and that's what we used as our starting point to develop a list of research questions that could be used to help improve gender considerations in AMR research. And as you can see, we did develop a large number of questions. So I really recommend that you check out our paper and project if you want to kind of delve deeper into some of these questions. So I thought I would just provide some examples of how these questions could be applied instead of going through all of them because we have so many. So in the context of, say, you wanted to implement a research program that was focused on improving vaccine access, if you were working on a research project that was in a low intensity cattle production system in Tanzania, for example, some questions you might consider from our list of questions would be, why do cattle producers of different genders choose one vaccination over the other? If there's gendered risks influencing the particular selection of different vaccines, and then what opportunities might exist to enhance vaccine uptake among cattle producers of different genders. And then, sorry. In contrast, if you were doing a really similar research program that was looking at vaccine access, but instead you were focused on low intensity poultry systems in Tanzania, because those systems are predominantly managed by women, some questions that you might consider would be different than the ones you considered for, cattle production. So specifically, you could ask which women poultry producers are interested in using vaccines but might face barriers in accessing them, who controls access to vaccine-related information, and what's the reason behind this control? And then how can access to vaccine information be improved among women poultry producers? So those are just kind of two examples. Again, we did develop a large number of questions, and we're hoping for our next phase, actually, what we'd like to do is apply these research questions to a project in the field and apply this framework that we've developed to a project in the field, just so that we can further validate it and refine it as well. And again, so we developed this project initially just as a starting point for researchers who are hoping to kind of address gender in their projects going forward. And because, as I mentioned, this was a gender gap that a knowledge gap that we identified, and it is important, and there's an increasing expectation that AMR researchers are integrating gender into their work as well. And I know we are going to get into this in the next part of this panel that Masika will be leading, but I did want to comment that, clearly there is a big link here between gender, AMR, and WASH. And we know that gender and social norms affect access to all resources, including WASH opportunities as well, too. And just as a quick example of something that we found with this research, we did find that, one study from Cambodia showed that women and children were at higher risk of developing AMR gastrointestinal infections because of their increased contact with manure and slaughter products. And so that would be an example of a case where, improved access to WASH would reduce this risk overall. But I know that myself and the other discussants can talk further about some of these intersections going forward. So thank you so much. That's kind of everything that I wanted to mention about this project, but let me know if any questions.
Thank you, Fiona. And the link to your publication has been put on the chat by one of our colleagues. So I wanted to mention that we don't often see the intersectionality of gender, WASH, livestock, and AMR being spoken about a lot. And to me, even your presentation and your research is very interesting. And I want to go straight to the questions and focus specifically. I'll even start with you, Fiona, and try to understand, why do you think gender is largely overlooked within the livestock and AMR research? And what changes do you think can be applied within the next 10 years?
Yeah, I mean, I think that's a great question. I think there's probably a lot of answers to it. I think in my opinion, one of the reasons that it's overlooked is that, I think in general, gender's been and equity considerations have been overlooked in research in general, but I think specifically in AMR, because it is such a complex problem, and we are trying to address a lot of things at once, even with our One Health focus and trying to be interdisciplinary. Sometimes we can lose a sight of incorporating other health focuses. So, I think going forward, making sure that we do have an interdisciplinary approach, which I know does come up a lot with our idea of One Health, but also, incorporating social sciences into this kind of traditional AMR research would help, I think, drive better social and economic understanding of social and economic factors that could help incorporate better gender and equity considerations overall. But in general, I do also think, the lack of gender consideration does come from also a lack of integration of women and other underrepresented genders within research as a whole too. So I think also making sure that we have those voices and we're promoting those voices is important too.
Thank you, Dr. Fiona. I will go straight to Dr. Om. And we want to talk more about WASH and the work that you've been doing. So how big is the problem of inadequate WASH and how does it impact AMR specifically? You might also answer this through, from the WaterAid perspective, what have you been doing to ensure that you're addressing this, especially within the developing nations or the lower and middle income countries?
Thank you very much, Masika, and hi everyone. Good afternoon, good morning. I'm very thrilled to be here today to discuss about this important issue. Thank you for this good question, and I will address into two parts. You mentioned how big is the problem and how WaterAid is contributing it. Let me start with how big is the problem. So as you all know, access to safe water, sanitation, and hygiene services and good hygiene practices are fundamental and foundational to human health, dignity, and prosperity. And lack of wash services and good hygiene practices are significantly contributing to the disease morbidity and mortality. There are so many diseases directly linked with lack of wash such as high prevalence of diarrhea, cholera, typhoid, pneumonia, undernutrition, foodborne infection, neglected tropical disease, environmental enteropathy, and also the lack of facilities and also behaviors frequently contribute to the occurrence of multiple disease outbreaks, including pandemics such as COVID-19. And more importantly, we have seen that lack of WAS, meaning high prevalence of hospital-acquired infections that lead for increased antimicrobial resistance. Currently, we all are fighting with the silent pandemic, which is antimicrobial resistance. But then provision of WAS services and good hygiene practices can prevent the infection, thereby to reduce the antimicrobial resistance. As we talk now, globally, around 700 million people lack clean water, 1.5 billion people lack basic sanitation, and 2 billion people lack basic hygiene services into their home. So achieving SDGs, for example, SDG target 6, which is universal access to WAS, by 2030 required 2 to 3-fold increase in current rate of progress. Similarly, attaining in this in low-income countries needs it needs 6 to 16-fold increments. So there is already a disparity where the services are. And more importantly, as we discussed, half of the healthcare facilities do not have WAS services into their premises, primarily hygiene services. So I just would like to emphasize that as we speak, in every 2 seconds, let me repeat, in every 2 seconds, a mother gives a birth to a child in a clinic where there is no WAS services. Can you imagine our health workers touching a newborn baby without washing hands, and mothers cleaning them immediately after delivery if there is no WAS services, no water, no clean water? What happens? Both mothers and baby are susceptible for infections. Healthcare workers touching new baby without washing their hands, the babies are 3 times more likely to get infection, including sepsis. And of course, that means both of the newborn baby and also the mothers are exposed with the hospital-acquired infections, and that pose greater risks and resistant antibiotics. How big is the problem on AMR? Each year, we estimate globally, 7.7 million deaths that are caused by bacterial infections. Out of 7.7 million deaths caused by infections, 4.9 million, which is almost 5 million deaths, are associated with the bacterial pathogen resistant to the antibiotics. So that means AMR kills around 5 million people every year currently. But as we know, the 50% of those hospital-acquired infections are resistant to antibiotics, and of which 60% can be prevented by good hygiene practices and also WAS services. But unfortunately, lack of WAS and poor hygiene practices in healthcare facility making community more threatened, and also severely impacting the AMR prevention global effort. So lack of WAS meaning high level of infection, increased antimicrobial resistance, and many preventable death. So how, then the second part of your question is how WaterAid is actually contributing in reducing antimicrobial resistance. So as you know, WaterAid is one of the world-leading international charity. We exclusively focus on working on WAS in more than 26 low and middle-income countries. Through our efforts, we have reached already more than 30 million people in low and middle-income countries. Our WAS intervention, programmatic intervention, primarily focus on communities, healthcare facilities, schools, and institutions. So our focus is on WAS. So that means we actually contribute in reducing infections, and that means reducing antimicrobial resistance. We operate in 3 levels: at the global level, at the country level, as well as at local level. At global level, we do an evidence-based advocacy and influencing program. For example, we use evidence to inform our influencing work. For example, recently, WaterAid has conducted a multi-country study to estimate the hospital-acquired infection in 7 countries, for example. Our study shows that in 7 African countries, 2.6 million infections, 270,000 deaths per year. And then countries are using 2 to 10% of their overall health sector financing for treating infection. One country, specifically Malawi alone, spent 3% of their overall health sector, overall GDP to treat hospital-acquired infections, while they only need $6 to $9 million US dollar to attain universal access to us. So that means the countries are not literally prioritizing in reducing infections, whereas investing lots of money on treating infections. So we use those evidence to inform and influence government. At national level, we support national government on developing standards, the guidelines, and roadmaps. We have been supporting more than 14 countries to develop WAS and healthcare facility standards. Some has already been completed, and we will be doing that. At local level, we model WAS services, water sanitation hygiene services in healthcare facilities, so that healthcare workers do have accessible, sustainable WAS facilities. Those are acting as a precondition to practice the behavior. We have been operating in multiple countries. Similarly, WaterAid we are leading as a world-class hygiene behavior change intervention in multiple settings, including healthcare settings, so that we change the behavior of the healthcare workers, so that they ensure the standard operating procedure to ensure the quality of the service in order to reduce the infections. Because of time, I'll just conclude saying that WaterAid we also model on integrated programming. So we use existing public health programs such as immunization or nutrition to integrate hygiene, so that we maximize the public health benefits and reduce the hospital-acquired infections. At the same time, WaterAid also responded multiple public health emergencies. For example, COVID is one of the key examples, I would say. We have implemented the multi-country COVID response in more than 26 countries, achieved and reached 242 million people. And we have added a significant contribution in suppressing the virus, and also through the collective global efforts in the world, including vaccines. The pandemic is managed timely without being too much resistance to the vaccine and drugs. This demonstrates the collective intelligence of managing infections and reducing risks. So I conclude saying that we believe that our programmatic and influencing work on WAS, adding a significant milestone in reducing AMR, while sometimes we measure the infections, but majority of the time we measure behavioral outcomes and WAS sustainability.
Thank you so much, Dr. for that comprehensive response. And I just want to remind the audience that one of the target for this goal, 110-100, was to save 10 million lives by 2040. Now, you've already mentioned that 7.7 million deaths are caused annually by bacterial infections, which are preventable if WASH services are accessible. Now, my question goes to Angela, bringing out the gender dimension. How does the gender dimension or gender shape access to WASH services, and specifically for women and girls? And what do we see the linkage with this in terms of the consequences for AMR risk?
Thank you, Sophie. I think one of the things, I keep saying that for me, data is really important, and data drives what I do each and every day, but not just data, but data that is credible. And for me, credibility in data comes from the people who are most affected. And what we do at White Ribbon Alliance, our approach is very simple. We never start anything without going to. We don't even read what has been done in the past. We don't read a lot of reports. We come later to do that. We start by asking women and girls whatever we are asking them for means to them. And so a few years ago, in 2019, 2018, there was a lot of issues. There was a lot of deaths around. I mean, there was a lot of talk around quality of care being the leading cause of maternal mortality and newborn mortality. And so we sought to ask women and girls, what does quality healthcare mean to you? We started with 1.2 million women across the world. But so far, I can say, because that became the foundation of our work, we've reached almost over 7 million women across the world, asking them issues to do with what they want most. And one of the things that really struck us is that women told us that WASH was the key leading denominator for them in terms of what they want most for their healthcare. And we went down to understand, what does WASH mean to you? In some countries, respect came as the first one and it was linked to WASH, but WASH came as the second. But in Kenya and most of the East African countries where I work and live, they said WASH was the key thing. And so we went further to understand, what does WASH mean to you? And they told us that WASH means clean toilets, clean water. When I go to brush my teeth, when I'm in the delivery room or in the labor ward, when I'm in the postnatal ward, when I've taken my child when my child is sick, clean sinks, clean toilets. And what was really pressing for me is because for the longest time, having been trained as a midwife myself, my first degree is in midwifery, I'd always thought that smelly hospitals is actually an indication that it's a hospital there. I didn't realize it was actually an hygiene issue. It was a wash issue and the like. And so they were like, we are tired of smelling places. When we go to the washrooms, they are all tainted. They are not cleaned. We are meant to share beds. They are dirty. We are meant to share beds with strangers. They are dirty. There's blood stains everywhere. The midwives equally told us the same thing, that we don't even know how to treat. I mean, we really just have to rush, clean what we need to use because we don't even have enough and there's no clean and running water. And that caught us so much. And so we went deeper again to the communities to find out what exactly then do you want to see done? And they prioritized the things that they were doing. But then we've been listening over the years to understand what does this mean. And we went deeper to analyze much more to understand where is this coming from. And now coming to your question, I think one of the things we've realized and we've learned all along, we assume that whenever we are doing any programming, any policies, any resourcing, that we are talking about an homogeneous group of people, men, women, and everyone else is the same. We forget that women have so many roles. We used to call them triple roles when I was in school, but I think they are much more. One, we have the traditional roles that women play. Women are the ones who fetch water. They walk for distances. They go fetch water. Sometimes the water is clean. Sometimes it's not clean. They are the ones who take care of people at home. They're the ones who do the cleaning, the hygienic conditions, and the like. That already is something that is only for women alone. Two, they are the caregivers at home. During COVID, we saw a lot of women who are getting infected because they were taking care of people who are sick. They are the caregivers in the homestead. During the Ebola crisis, there are many things. During cholera outbreaks, women actually end up suffering, women and girls, because of the mere fact that they are the caregivers at home. And if the conditions are not conducive, there's no enough water, like in most of the settings, the women that we work with, there's a problem. There are healthcare roles, community health workers in our communities, nurses and midwives. Majority are women. They're taking care of people who are sick. Most of the times, there are not enough wash facilities, as women and girls told us. That's already a problem. And then the last thing is the fact that they are the ones who give birth. They're the ones who go to those health facilities. They are dirty. They have gaps in wash. And though that tells you that women are placed at a higher risk of getting infections. Now, it does not end there. When they get sick, where do they go to seek care? Most of them will go to buy either over-the-counter drugs because they can't afford. Again, the economic aspect of women. Women told us that they want money in their pockets to be able to go and access quality health services because most of them do not own resources. So again, agenda gap. So they'll either ask someone who has not finished the antibiotics, or they'll go to the facility, they'll go to the chemist in the nearby, or they just buy for 1 or 2 days because that's what they can afford. And then what does that leave us with? Resistance. So it becomes a vicious cycle. So we see the whole different layers of how women actually, the different issues that really place them at a higher risk. And even as when they are sick, do they go to really seek the quality care? They go to buy, they don't finish the dose, or they don't get the whole dose, or they actually don't need it and they go to buy it because that's what they can afford. They don't have fare to go to a health facility. They can't even attend, they can't afford even to pay for consultation in those facilities. At the end of the day, what do we end up with? A whole cycle, resistance and the like. So I think, in short, to answer your question, that is how I see this playing out, and that is what we do. And so just to answer a question around what have we been doing, for example, to address some of the gaps, it's literally evidence generation. What are the people saying? What are women saying and girls? What are we hearing? What are they saying about their newborns? What are the frontline healthcare workers saying? And what is that evidence? And not just evidence that is the numbers. It's actually the real stories, the package stories, the real experiences, because they say the wearer of the shoe is the one who knows where it pinches most. And then beyond that, pushing for policy change, advocating, but most importantly, is actually literacy around antimicrobial resistance, around WASH. What is it that they need to do? What are the investments that are really needed? But also at the primary care level. I always believe in the whole thing around invest less now or invest more later. We either invest in prevention, in quality WASH, or we invest more in curing, in treating that which cannot be treated, which is already resistant. And I think that's what we are struggling with at the moment. Back to you, Sophie. Thanks.
Thank you so much, Angela. And I want to add on the triple roles that women play in our communities, especially the low and middle income countries, and take it to the livestock sector with Fiona. We know women are also they raise animals within the households. They are the ones who keep the livestock. They look for water for themselves, but also for the livestock. And now, I want to understand what are the challenges or the barriers that we have been facing within the livestock sector in implementing gender-responsive interventions, and how can policymakers, as Angela said, there's also an element of policy making or policy changing. How can policymakers address them? Fiona.
Yeah, I think that's a great question. I do think that Angela kind of touched on some of the answers that I'll give as well, too. I think in general, there is that gender inequitable access to resources, specifically in the livestock sector. And as you mentioned, Masika, like women are in many countries, doing the brunt of the labor around that and the brunt of the livestock raising specifically for subsistence level farming. So I think making sure that they're included in these discussions and making sure that we're supporting community-based models and incorporating their voices in can also help improve these policies going forward. So I think making sure that policymakers are aware of that and are doing that is important. And I think, when we are talking about, which I think Angela also mentioned, but when we're talking about targeted education around AMR and WASH, as she mentioned, but making sure that they're receiving this education and training as well too. And so that needs to be gender sensitive. So we're making sure that we are engaging them in a way that they understand and that they're able to attend these sessions if we're organizing particular sessions. So I think targeted education and training is really important as well too. And then I think also educating, if we're talking about awareness as well too, educating extension services like the agricultural extension officers and veterinarians who are providing this information, making sure that they're also gender sensitive or gender responsive as well, so that they understand some of the gender dynamics. So they're making sure that the women who are contributing to livestock development, that sort of thing, are being educated on that as well too. And I think, with regards to your overarching question about kind of how we can get policymakers more in that, I think, bringing that awareness to policymakers is important. And that's done through, I'm sure through Angela's research and research like we're doing here at Global Strategy Lab, just encouraging people to incorporate gender into their policies going forward more. And I think, also encouraging policymakers to have that political commitment to that going forward, like political commitment to encouraging gender and equitable considerations going forward, making sure that's written directly into the policies. And I think that will just improve and ensure that AMR programs are going to be more gender responsive and more gender sensitive going forward as well too.
Thank you so much, Fiona. And I want to direct my next question to all of you. So perhaps Dr. You'll start with answering this question. We know that especially policy at either national or global level, we need to do a bit of advocacy, a bit of influencing for policymakers. If you had a chance to sit down with someone who has a policymaker who has an opportunity to make change, what would you ask them to do? What specific action would you want them to do to ensure that we are tackling WASH access, that is also tackling AMR and this agenda responsiveness within this action?
Very great point, Samika. So I think if I had a chance to sit with the policymakers and donors, I'll request two things. One, I would ask them to think big and act fast. This is already too late for now for AMR. I want them to focus on addressing the root cause of AMR at a scale rather than only focusing on the symptoms. While I recognize and we recognize from WaterAid that while the research, diagnostics, and treatments are important, but the prevention, such as provision of universal access to wash services and hygiene practices, are fundamental. That's where we will be actually addressing the root cause of AMR by reducing the infections. So this means the investing to drive the large-scale AMR and wash programming to reduce the AMR. So in this context, I think one of my urgent requests would be call all member states to urgently finance and enable financing for their commitments, because the member states has committed to ensure universal access by 2030. That was also the commitment by 2024 UN high-level meeting on AMR, and then also the 8 member states has committed to ensure the IPC, at least in 90% of the healthcare facility, they want to have WHO minimum requirements for infection prevention. So I want to remind them, I want to make sure that they allocate sufficient financing to do that, and acting big and fast. That's first. Second, my ask would be more on integrated programming. I think there is more and more integrated programming are necessary, primarily WASH at the core and center of AMR, IPC, nutrition, livestock, and disease prevention, or even outbreak and pandemic preparedness. Since WASH is foundational for attaining multiple sustainable development agenda, is it possible? I think it is possible, and it should be the case for AMR. And any of these integrated programming should be integral to use equity and inclusion framework since the inception, and so that those programs are more gender transformative. And this integrated programming should also strengthen system to ensure the sustainability. So if I had a chance to sit with them and talk, so two things: think big, act fast, focus on integrated programming, focusing on prevention. Back to you, Fiona.
Thank you, Dr.
Oh,
I hear
Masika.
the need to raise the urgency on AMR being prevented or tackled now, and also the fact that prevention is at the center of the intervention and looking at it from a multi-sectoral integrated approach that touches on human health, animal health, and the environment. Thank you so much. Dr. Angela?
I think if I was to sit down with a policymaker, first I would take them through an education program. And I would want to educate them and I say that because a lot of the policymakers that we have some of them have no idea of what we're talking about. So I would first take them through a literacy kind of thing to see to see the link, just as Dr. Om is talking about, where I need to show them the link between health, WASH, AMR, and economic empowerment, and why that is really necessary. The second thing I'll educate them on is around going back to the basics, primary healthcare, where everything was integrated, because I think we've siloed and verticalized everything and made everything curative. And that's where our problem is. So if you can go back to the basics first, that would be the starting point. Educate them on why it's important to do prevention promotion. Educate them on why it's important to integrate and where the integration is, because I feel a lot of times, if I'm a health policy maker, I only think health. I don't think health and the linkages between even livestock. I don't think health and agriculture. I don't think health and WASH. I don't think health and economic empowerment and all that. Then the third thing that I'll do, I think I will really push them narrative around, it's not just about policies that you want to make them. You have to ensure that the policies are followed up with an implementation framework for the same, and also funding and financing for the same. Because a lot of times they say, oh, we have these policies in place, but those policies are not, they're just policies, they're documents. So I think for me, and then the fourth thing that I would really want from them is an accountability framework to track those commitments and the like. And I will not do that alone. I would actually do that with the voices of the women and girls. There's 6 million women and girls that we've been working with behind all that, because a lot of these people need evidence and the like. And I'll show them the call to action from these women and girls and what they need to do. And actually they become the accountability partners to these policymakers. I say this because a lot of times when I look at what policymakers do, and a lot of us, what we do, a lot of times we think that it's only other people are doing it. Let me tell you what has really made things not so good is actually our sector, the development sector. A lot of times it's because we go in and with this commitment, we have this policy, we sign these MOUs, we take very nice photos, we post, our egos, our logos are there splashed all over the place, and then we go. We never go back to find out who does the follow-up, where's the accountability and the like. The next thing we do the same. We are as much failing our women and girls, our communities, just as those policymakers, because we have made it more of a business, more of a show, more of it's whatever shines to the cameras, whatever, oh, it was this organization that did this, was this. That's not what women and girls want. That's not what communities want. Women and girls want change. We want to deal with AMR. And if we are to do that, we have to do it in a different way. So instead of just talking about the policymakers alone, we also need to introspect and ask ourselves, how are we holding ourselves accountable? Because we keep on blaming them. But actually, they are the primary people to blame. We are the people nearer to the policymakers, but we have made it about us, what we are going to put in our reports, what we are going to do ABCD. We are never caring about how does this go downstream. So I think there's a place of, even before I reach the policymaker, introspection. And actually, the other question I wish you asked me is, what do we need to do to NGOs and INGOs and the like? Because we are the problem. We need to stop talking and become the actor. Stop blaming other people. Introspect and see what is our problem. We have a problem. Communities are demanding action, but we are going there pretending we are the communities. We have the problem. We need the real hard evidence, and that real hard evidence comes from the voices of women and girls communities. But we are going there pretending that we know it. We don't. We need to be the first primary policymaker to talk to before we even go to the policymakers. Back to you, Sophie.
Thank you, Angela, for that firm answer. What I've taken from you is we need to stop assuming that policymakers understand the different linkages and with economics and AMR and WASH, but we need to start from an educative point to show them this is what is happening, or educate them on what AMR is, what WASH is, and how the economics of care do not favor women most of the time. Now, I'll go quickly to Dr. Fiona before we take some questions from the participants.
Thanks, Masika. I mean, I'll honestly just build off of the excellent answers that Dr. Ohm and Angela just mentioned. I mean, firstly, from Dr. Ohm, I 100% agree. I think there's a lack of political will and funding behind this. So I think, as he mentioned, making sure that we really do have prioritized and allocated funding to these programs like WASH, AMR, and making sure, again, that we have these equity and gender considerations within them, and that there is like political commitment to encouraging or including that in there is going to be super important. And then, as Angela mentioned, I think, making sure that the political leaders are educated on the importance of it is going to be so important going forward as well, too. And then, as she mentioned, I think following up and making sure that we are looking at the impact of these policies, any policies that we're implementing, making sure that we are looking at the impact of them is important. And I would say maybe even one step beyond that, making sure that we are like really investing in data collection as a whole, not just the impact of our policies, but in the lead up to implementing any sort of policy. We should make sure that we have the data backing up what we're going to do, because I think it's really crucial that we have an understanding of how anything that we do is going to impact AMR, WASH, but also specifically, as Angela mentioned, how that might impact the different genders and different groups that are going to be impacted by the policy anyways. And I think, as she mentioned too, making sure that we do have like partnerships with local communities and local organizations to provide that insight, provide that data is going to be really crucial to making sure that we have, from my perspective, like gender responsive policies, but also that we're just going to have sustainable and effective policies addressing WASH and AMR going forward. But yeah, I totally agree with all the answers so far too.
Thank you, Dr. Fiona. And you highlighted what Angela mentioned about not coming with I know what you need when you go to a community, but going with an open mind and wanting to learn what the community needs first before you offer any solution. Now, we have quite a number of questions from the participants, and I will read the first question directed to Dr. Om. Provision of WASH and AMR are affected by climate change. How will our approach change in the future where more extreme weather occurs? So quickly, Dr. Om, so that we get through all the questions, if possible.
Thank you very much. I think that's a great question. Definitely, we should be addressing climate when it comes to water, sanitation, and hygiene. We need to make sure that our response is climate resilience. Our technological solutions are climate resilience. We are agile. We should be thinking about what happens to the people. People should be understanding the coping mechanism. But at the same time, I think making our WASH intervention resilient to the climate, irrespective whether this is a source to water. Of course, then we have been also experiencing lots of climate-related vulnerabilities, consequently, and either devastating effect on the already installed technological solutions or the post-climate-related aspects. For example, post-flood situations where emergencies is actually the public health emergencies are being expected. So how do you make sure that our response is quite adequate when it comes to offering quality service, timely service, and making sure that those services are ensuring the quality aspects of the intervention, so that the infections are reduced and subsequently the resistance on microbes is actually being addressed. So my specific question, my specific answer to this would be, we as a WASH sector, the climate, we should put climate at the center when we are addressing WASH. Whether this is making community more resilient to climate, whether we are making our technological solutions resilient to climate, or whether we are making government being quite responsive while addressing the WASH solutions and other solutions, making it climate resilient. I think we also, for example, I mean, this is often I say in any of the forum like this, for example, people might come up with different solutions. People might say, oh, what are the alternative solutions when it comes to flooding, for example? People might say, oh, we will build the technology at the high standards, or maybe at the level where the flooded water is not reaching. But the people during flooding, people cannot reach those toilet facilities, for example. People may not reach those hand washing facilities where we have installed. What are the alternative solutions that we are actually, we as a sector, putting in place place so that people can select those alternatives technological solutions when it comes to receiving service during those situations. So, and then also the sector, how educatedly we are assessing those vulnerable populations and vulnerable society, so that when we make decisions, whether this is a policy decisions or technological decisions or approach that we are going to implement, is going to be more on climate resilience. So being sensitive to this and making our policies are resilient, but at the same time having adequate financing and working with multiple actors into these areas of work. Back to you. Quite important areas to address.
Thank you so much. I think this is a very interesting and important area. We are talking about a demographic of people who are already influenced by very many other things, and then you bring in climate and drought and farming and all these things. So as we are also discussing it, I think it's important that we become sensitive to climate and its impact to all these other elements. Now, question to Angela, and I think you've already touched on this. What is the role of civil society in improving access to WASH, and what are some examples of CSOs that are involved in advocacy based on a One Health approach?
Thank you. One of the things that we have already been doing, we are a CSO as White Women Alliance as a movement across board, is actually the evidence generation, and not just evidence that is from books and the like. It's actually evidence from the women and girls themselves, generating that evidence around WASH and unpacking what WASH means in a broader scale, because WASH can just, some people hear WASH and they think WASH is water, WASH is just sanitation. People pick whatever they think is they can run with. So generating that evidence, but not just generating that evidence. Our approach is very simple. We ask, we listen, and we act. So when we go into the communities, we will go to ask a question around WASH or water or whatever it is that we want to ask, or women are talking about, and that links how that affects their health and their health-seeking behavior. After that, we listen to them as they prioritize, because and we don't just listen to one group of women. We know that women and girls are homogeneous. And I mean heterogeneous. Women are not homogeneous. So we have women with disability, women living in rural areas, women in refugee settings, women in informal settlements, women in nomadic settings and the like. And all those have there are different ways in which WASH interplays in those places. So we listen to all this, and then we bring them together to prioritize what are their key things, what are we hearing from all of them. And then with them, we start acting, we set up action agendas. And it's these action agendas now we use to demand accountability from their different actors. It's not just policymakers, but even the practitioners, the people, the different ministries, because we say there is the interlinkages and the like. And then we don't work alone. We collaborate with other civil society groups, but most importantly, we collaborate with our what we call the Women and Girls Action Networks for Change, which are either the Village Action Networks or the Community Action Networks, made up of women groups, men groups, boys groups, girls groups, different groups of people, because all of them have different agendas. Everybody comes up, I mean, everyone has an action in those action agendas. And then after every 3 months, 6 months, 1 year, there's tracking, including the policymakers themselves. So it's a whole accountability framework where there's citizen hearings, there's audits, and all that is done, community journalism, and then we use what we call solutions through storytelling. So we have different groups across the different places where we work, and they're the ones that are the grassroots groups that are really leading the change at that level, holding these policymakers to account. I'm just giving you an example of some of this. What are some of the things that we've been able to do that we've seen results? One is like for pushing for WASH for women and girls with disability in healthcare settings, where we have had disability-friendly toilets that have been installed, but also disability-friendly sinks for those women who could not be able to do that, those living disability. In spaces where we have, like, for example, in the nomadic settings, where we have water management committees, where women and girls, there's their time for going to fetch water, and then there is a place where the men now go to feed their, to whatever they are, to take their livestock to drink water and the like. We are also working with groups that are teaching women how to harvest water. For example, in the nomadic settings among some of the Maasai communities in my country, Kenya, their manyatas are made up of mud. So we have had to work to see how do we improvise some of this with polythene to harvest this water. How do we subsidize the water tanks, bring women together, and they can be able to borrow some money and actually buy water tanks, and they can harvest the rainwater and they can use it where there's a problem. In times of drought, coming and partnering with different partners and groups to actually dig earth dams. And those earth dams are managed such that there's no conflict between the wild animals, the animals themselves that are really like owned by the men and the women themselves. So there are different ways in which we can talk about that we've been able to do and we are still doing across board. And then using some of these stories to really show that it's change that can be realized at the end of the day. It's not complex. It's just a mindset that needs to be shifted so that we can see what needs to be done at the end of the day to ensure that WASH is addressed across board. I've just given you a snapshot of some of the things that we've been able to do, but there's a lot that we are doing and we are still doing. And there are many other CSOs that are also working with us. Thank you.
Thank you so much, Angela, for all the work you do across this sector. We have one more question for Dr. Fiona, and someone is wondering to what extent you integrated consideration of intersectionality in your questions and the framework, since you mentioned equity.
Yeah, that's a great question. I'd probably direct everyone to take a look at the actual project itself, but we did briefly discuss how intersectionality could impact the framework. So we did have a box in the paper exploring that a bit further. So the example I think that we gave there, we just talked about how in a study from India that looked at a dairy cooperative there, it found that caste was a significant factor that impacted or interacted with gender to influence how women were able to access services for their dairy animals there. So I think just an example of how other factors will play a key role in influencing outcomes besides just gender. But definitely, I think intersectionality is something that we didn't get a chance to explore a lot of just with our limited word count and that sort of thing with our framework, and definitely something we'd love to explore further in the future applications of this project. So when we are applying this in the field as the next step, something we'd want to consider is how these other factors can play a role. And I mean, we know as we're talking today, we're making these links between AMR, WASH, and gender. So we know that there are lots of links here. And so I think, it'll be important to address this going forward. And I think that intersectionality is probably a under explored area that we need to look into and delve into further.
Thank you, Dr. Fiona. I wish we had more time to continue this discussion. I have seen a very interesting question that I think we should answer very quickly. Dr. If you can do this in 1 minute. How do we measure the financial burden of AMR due to inadequate WASH? And I'd like you to answer this from a broader perspective, not just the human health, but because this cuts across all the 3 sectors of health.
Definitely. I think one thing that we should definitely, from the health point of view and from the WASH point of view, we should be thinking how much we are actually spending country's budget to treat these infections versus if we invest on solutions, for example, putting hand washing facilities, sanitation facilities, water supply systems in place and promoting the behavior of the health workers, reducing placement of those facilities and also health workers practicing behaviors is actually can reduce the hospital-acquired infections. We know that 50% of those hospital-acquired infections will be resistant to antibiotics, for example, right? So we know how much investment that we can put in place and how much return that we can get it. So if we continuously invest on reducing the infection, so that means in long run we are reducing the antimicrobial resistance. I think that's the core aspect that I would think we should be thinking about long-term investment, trying to address the root cause. That will definitely level up for return on investment on the WASH, primarily looking to AMR. And then from the other aspects, I think AMR is multisectoral. We should be definitely thinking about animal health, human health, diagnostic research, surveillance, and so forth. So when we think about humanity, and then of course if anyone got infected, then that person has to be treated. That person has to be responsive in terms of vaccines and in terms of other interventions. So we should not level up in a case that, if we invest, for example, on this particular areas of work, but how much we are going to get out of it, right? So is a humanity and the human outcomes, the reducing infections and also preventing death is fundamental there. But when it comes to selecting intervention, which intervention is going to have a bigger impact in long run, how many people that we are going to protect if we invest in a specific areas of work those are are fundamental for us to look. It's similarly from the animal point of view, animal health point of view. I think those huge vast areas of work where the crisis has to be addressed when it comes to AMR. I think from the sectoral point of view, from the government point of view, I think weighting the intervention effectiveness, but at the same time, they're looking for return on investment. At the same time, how much impact is going to be secured, investing on which particular intervention. This has to be weighted very efficiently. There are lots of data into the sector in terms of which intervention will actually be more cost effective and offers a quite return on investment. But this area still need to be explored and judged. We are at the early stage of the making those case to the sector. But we know from the facts that investing on addressing infections will actually have a huge return on investment. As I mentioned, I think just to conclude on this, as I mentioned earlier, and we have witnessed that countries are spending their 3 to 10% of their GDP just to treat the infections, and while they only need few millions to address the universal access to wash. So isn't it the cost-effective solutions to reduce, invest on putting the wash facilities and behavior versus treating the infections? So I think making that judgment and prioritizing at the country level is quite vital. And we, as also Angela also mentioned earlier, I think we as an individual working in different organizations, whether working from civil society or from donors or from different angles, we have collective responsibility to offer more science-based, evidence-led facts to the government, so that when policymakers make the decision, that those decisions are quite sensitive to the evidence and science. Thank you. Back to you, Masika.
Thank you, Dr. And from your answer is we need to prioritize the cost-benefit analysis of AMR and the implication that comes with it if we don't improve our wash services. So we have come to almost the end of this webinar, and I want to do a quick summary on the interesting topics that you've all talked about and the questions that have been asked. So I don't know about you, but I've enjoyed this very much. It's been very knowledgeable. And the key to this, or the foundation of this, is that AMR is preventable. AMR is urgent. In terms of tackling AMR, it's very urgent. Our leaders have to make commitments, but they have to back those commitments with political will and also financial commitments to make sure that these interventions are implemented. Humanity has to be at the center of it. We need to think about the women and girls. We need to think our communities. We need to think about the livestock keeping communities, the environment at the end of the day. We also need to be very sensitive about the different dimensions that AMR comes with. There's a gender angle, there's a wash angle, but there's also the multisectoral health angle that AMR impacts. We also need to deal with the root cause of the problem, rather than being a responsive nation or community who just responds when we can prevent, which is more cost effective at the long run, and centers equity because it prevents people from actually going through the burden of AMR rather than preventing it from the beginning. So it's been very educative from my end, and I wish we had more time, but we've come to the end. So with the 2 minutes that we have left, I want to we'll launch a survey just to ask you a few questions to see whether this was a beneficial conversation to have, and maybe we can have this a little bit later. We will also share the recording of this webinar, presentations that were shared, and any documents that might be useful for the discussion around WASH, AMR, and thank you so much.